This is the patient's right side nasal cavity. You can see a lot of greenish yellow pus blocking the entire right side. Now, I'll be going inside the patient's left side nose. You can see it's completely normal. The patient has a good amount of space for the airway, for the inhalation and the exhalation, the process by which the patient breathes inside. You can see it's completely intact, no fungus, no pus whatsoever. So this patient has basically allergy towards fungus, and this kind of fungal infection completely involves one side of the face where all the sinuses get blocked, followed by complete severe headache on that particular side, nasal blockage, nasal discharge, could be foul smelling as well. Sometimes, if severe, can affect the vision because of the compression from within the sinus just below the eyeball, that is in the cheek. So, as you can see right now, I'm trying to use my suction and clear up the area somewhat. So, this is just to understand the anatomy much better. So when the patient first presented to me in my OPD, he had the same findings, but very less in intensity. So I explained the patient the need for surgery, although he was not willing for it. You can see the hypertrophied inferior turbinate polypoidal mucosa, behind which you can see a huge boggy uncinate process. You can mistake that for the middle turbinate, but it is actually the uncinate process. You can see the choana is completely full of multiple polypoidal tissues. Now, this is a procedure where I'm trying to decongest the right side nasal cavity of the patient. I use 4% locks with 2 ampules of adrenaline. So I preferably used a long gauze piece for decongestion in this patient instead of the usual net cell. So after the decongestion, you can see there's much of the swelling has gone down, and you can see a sticky, cheesy uh, secretions. You can see along with the yellowish white fungal concretions inside. So now you can see after decongestion, the entire nasal floor has been exposed and the choana is almost visible. So my first step would be to take my micro debrider. You can see this is a shaver, also called as a micro debrider. I'm going to take away all that fungal debris and polypoidal material from the choana. So this is basically to avoid the choanal banking effect and to understand the anatomy of the posterior nose much more better. So this is the micro debrider. I'm trying to shave off. You can see, if you can see a lot of bubbles oozing out like this, indication that's purely a sign that the debrider is blocked. So you got to make sure that you open the debrider and clean the suction system of the debrider. So far, the patient's middle turbinate on the right side is not at all visible. The only structure visible is the inferior turbinate and the hypertrophied uncinate process up there. So you can see I'm trying to remove whatever polypoidal tissue I can see. Not sure about the middle turbinate yet, but definitely I'll be looking for the presence of the middle turbinate once I remove all this polypoidal tissue. Now be careful, sometimes the middle turbinate can also undergo a similar polyposis, and you may accidentally take off the lower half of the middle turbinate. But anyways, you're supposed to remove that polypoidal tissue, but knowing it before removal, that whether or not it is middle turbinate, is always better. You can see a somewhat of high level DNS to the right side. Now you can start seeing a lot of fungal concretions inside and a lot of polypoidal tissue. So basically, I'm trying to open up the region of the patient's choana on the right side. So probably this tissue looks to be like middle turbinate. Now the usual method to locate the middle turbinate is to decongest the area and have a look at the axillary area. But because of the excessive uncinate process edema over here, we are at present not able to see the axillary process, the axilla. Now, after having removed somewhat of that polypoidal tissue blocking, you can see now I'm pointing out at the middle turbinate. That's the axilla of the middle turbinate. You can see the severe bulge from lateral to medial side on the uncinate. You can see I'm trying to press on that uncinate process. It's so soft and boggy, suggesting that it is completely full of pus behind the uncinate, and there's a lot of collection in the patient's maxillary sinus. Now, So we have definitely located the middle turbinate, and you can see a gentle pressure on the middle turbinate is oozing a lot of yellowish pus from within the middle turbinate. So you can imagine the amount of pressure building up in this patient's right side maxillary sinus. Now the patient had severe headache on the right side frontal area, and on the cheek area also patient started having numbness in the upper teeth as well. So you can imagine the amount of pressure of the fungus building up inside. So now we have identified the patient's middle turbinate. We also know the patient's axilla's location right now. And so the patient's middle turbinate, lower one third to lower half, was actually it had undergone polyposis. So what I'm removing right now is the remaining part of the posterior nasal cavity, which had or has undergone polyposis. This is basically the posterior half of the inferior turbinate, which has undergone polypoidal changes. So definitely, before going on into the interior of the sinuses, you should always make sure that the corona is free to avoid any kind of coronal banking effect. So my first aim will be always to locate the anatomy first. Now that's the patient's uncinate process. You can see so severely boggy in nature. You can see now that's the patient's maxillary sinus ostium just behind the uncinate, and you can see a lot of cheesy debris, fungal concretions coming from that area. So after having opened up the patient's nasal cavity, and now I'm going to move on to the patient's maxillary sinus right now. So the usual method of opening up the maxillary sinus is to take a backbiting forceps and to chip off the tissue uh, just superior to the inferior turbinate, right? But in this case, as we already know that the anatomy is almost distorted and there's a severe edema in this area, so I'm not going to follow that procedure. So what I'm going to do instead is I'm going to take the curved suction, follow the superior border of the inferior turbinate, and you can see just a gentle pressure inside that area is causing a lot of fungal concretions to just come out. So you can see a gentle pressure moving along the superior border of the inferior turbinate at the area of the uncinate process. So let me get this very clear. You have to take your curved suction and slide, or you can say glide along from anterior to posterior direction on the superior surface of the inferior turbinate. Go a little behind the uncinate process and just try to enter the maxillary sinus. You will be directly in the sinus opening, which I just did, and you can see a lot of fungal debris coming outside right now. So this is a usual method. I do not follow that backbiting procedure in such cases because the anatomy is almost distorted. You may end up damaging the lacrimal system. So the safest method is to just take your curved suction, glide along the superior surface. What I'm doing right now is actually I'm inside the patient's maxillary sinus right now. So you can see a lot of polypoidal mucosa, a lot of polypoidal soft tissue along with the fungal debris. Now I'm going to edit this video. I'm going to show you mostly the important points only. So now what I've done is I've removed a part of the anterior ethmoids. Now you're going to expect a lot of capillary ooze because of the long-term infection, even though the patient was started on a lot of antibiotics for quite some time. You can see that's the patient's middle turbinate. I'm moving along the septum and I'm trying to open up the patient's sphenoid sinus just to know the level of the posterior ethmoids to be on safer side. So this is how we go for the sphenoid sinus between the superior turbinate and the nasal septum. You can see that's the patient's sphenoid sinus ostia. So I tried to find the sphenoid sinus and I could just under 5 seconds. So you got to go medially along the septum and between the middle turbinate and the septum. Now, what you can see me doing here is a turbinectomy Caesar I'm holding in my right hand, and I'm taking off the lower two-thirds of the middle turbinate. Now, if you saw the initial part of the video, the lower one-third of the middle turbinate was already polypoidal, which we debrided, and this part, which is the lower two-thirds of the middle turbinate, we are now actually going to take off and take it out. So this will give me more access inside. Now, a lot of people will be thinking right now after having seen this is that why am I removing the middle turbinate? Because the middle turbinate acts as a landmark for frontal sinus and it is an important landmark as such. But I do not believe so. See, I've already kept the upper one-third of the middle turbinate intact. The reason is because I will require the middle turbinate to help me guide my way to the frontal sinus. So that's the reason I haven't removed the entire middle turbinate, which I do not even intend to do so. So you can see the superior one-third of the middle turbinate along with the intact axilla is completely seen, which will help me guide me towards the patient's frontal sinus. Now, much of the anterior ethmoids I have already removed. Now I'm just trying to, take away all that polypoidal soft tissue from the maxillary sinus. Sometimes the debrider system cannot work properly in such heavy edema and fibrous tissues sometimes. So it's best I'm using a conventional instrument. So that is a huge mass. You can see the more pressure I give in the area of the maxillary sinus opening, you can see the same amount of fungus keeps on coming out. So you can imagine such amount of collection within that maxillary sinus. So no doubt the patient was having severe pain, tooth aesthesia, the tooth sensation aesthesia, also numbness on the cheek skin because of the pressure of the fungus uh, on the maxillary nerve actually. So you can see a lot of fungal debris. So this is whatever you're seeing right now is all fungus along with the allergic protein deposition surrounding the fungus. So you can see me using a debrider right now and you can see the debrider is not able to cut through that particular tissue because of its fibrous and dense nature. So what I'm trying to do right now is trying to expose the patient's posterior wall of the maxillary sinus. You can see the edema on the mucosa is so much, and still the patient's maxillary sinus is completely, almost still full of the fungal debris, even after having removed so much of fungus already. So in such cases, I will definitely strongly recommend using a microdebrider. At least keep it for emergencies if the instruments are not working properly, if you don't have any idea how to use it. You can see the amount of debris inside the maxillary. So whatever you can see is completely a huge opening of the maxillary sinus, but it is completely full of the polypoidal and the fungal material inside. I'm just trying to, expose the posterior wall of the maxilla much better right now. And you can see that's the uncinate bony chip, the horizontal part of the uncinate down there. Later on, I'm going to show you the maxillary sinus with the help of 70-degree endoscope as well. And as we already saw the scan, this patient's frontal sinus is so huge, highly pneumatized, but there is one important finding. Now, what I'm doing right now is this is the patient's 70-degree endoscope view. Now, the frontal sinus we saw as on the CT scan had a very huge interfrontal sinus cell as well, so which was opening up in the patient's right side frontal recess. That's the middle turbinate superior one third which I was talking about, kept intact, which will help me differentiate between the cribriform plate and the frontal sinus. So you can see that's the middle turbinate. Lateral to the middle turbinate, we have to stay lateral to the middle turbinate and medial to the lamina papyracea and posterior to the frontal beak always. So you got to stay a little anterior, don't go wander off too much posteriorly because the anterior ethmoidal artery is there. I'm going to also show you the anterior ethmoidal artery right now in some time. So we're going to be encountering two openings over here as we saw on the CT scan. Is that one opening which will be on the medial aspect, which will be the interfrontal sinus cell, and one on the lateral side which will be of the actual frontal sinus. So you can see I'm using a rad 60 blade for my frontal sinus debrider. You can see much of the tissue has come out. So one trick you have to remember is that you got to keep your endoscope below the instrument. You can see that's a tissue which is blocking the frontal recess up there. So I'm using my upward 45-degree angle Blakesley. That's the area of the lamina papyracea. You can see a lot of fungal debris on that area. So this patient also has a dehiscent lamina papyracea. You can see a small orbital fat popping out right now. That's the fungus. So you got to stay between the lamina and the middle turbinate and posterior to the frontal beak. That's the huge fungal debris along with polypoidal tissue in the frontal recess. So keep your endoscope stable below the level of the instrument. That's the area of the frontal recess. And you can see a huge mass of the polypoidal mucosa and the polypoidal soft tissue along with the fungal debris. That's the mass which was blocking the frontal recess area. You can see it's quite huge and it has a lot of vasculature on that. It could be also a polypoidal mucosa which got infected with the fungal infection, and you can see a lot of edema and fibrous tissue as well. So after having removed that, you can see there's a lot of space which we have achieved right now. So the trick here is to always keep your 70-degree endoscope below the level of the instrument. Your instrument should be at a level above the endoscope. You can see a little bit of pressure with the curved suction. You can see sticky, typical sticky secretions, typical of AFRS. Because this is because of the presence of mucin inside. It has got that sticky consistency to it. So this is typical of AFRS. You can actually diagnose this based solely on the radiological findings with a double density shadow on the CT scan. So you can see a little bit of opening on the patient's right side where my suction is right now. That should be the opening of the actual frontal sinus, and this should be the opening of the interfrontal sinus cell. A little bit of more use of upward 45-degree angle to take off all the debris and the fungal polypoidal mucosa. You can see a thorough wash and all the fungus is going to come out. So make sure in cases of AFRS, your main goal should be after opening up the sinuses as much as washes as you can give. And I can already see the opening of the interfrontal sinus cell. I hope you can see that as well. So we have a very huge fungal mass coming out as well again and again after the you can have a look at that. That actually came out from the patient's right-sided interfrontal sinus cell. So you can see on the CT scan, we saw that the frontal sinus proper and the actual interfrontal sinus cell was having a huge collection inside, and this is that collection which we saw on the CT scan. So you can see it's sticky, yellowish white, fungal debris along with polypoidal tissue inside. So that's the huge mass we removed from the patient's right frontal interfrontal sinus cell. And now I'm going to keep on giving thorough washes as much as possible so that all the fungus comes out. So what washes I'm giving right now? Now you can see that's a huge right-sided interfrontal sinus cell opening up in the right frontal recess. So that's not the frontal sinus. Always remember that that is not the frontal sinus. That is basically the patient's right-sided interfrontal sinus cell. Always remember that this is not the frontal sinus, but this is patient's interfrontal sinus cell opening on the patient's right side frontal recess. So this is how you did basically. What opening you can see over here is that's the actual frontal sinus, but you cannot see a proper opening. Also, the roof is blocked. Maybe some kind of a polypoidal tissue is blocking it. And you can see a huge bony septation between those two, as already discussed on the patient's CT scan, that the lower half of the bony partition was absent. That is brain basically. That's the patient's brain. That's skull base. That huge bulge which you can see over there, over the curate, That is basically the patient's skull base, behind which is the patient's brain. And if you try to remove that bone, the patient's brain will prolapse in the frontal sinus area, the frontal recess basically. So you can see I'm trying to drill between the two openings, making sure I do not drill on the skull base. Otherwise, the patient is going to have a CSF leak. If at all, there's a dural breach. So I'm currently using a 15-degree angled handpiece motor. You can see much of the bony thickness I have reduced. If you want, you can use elongated multi-hinged bone punch as well. You can see the huge bulge of the skull base over there, but I'm not quite satisfied with the opening of the patient's right frontal, but I'm very much happy with the patient's interfrontal sinus cell opening. So what I'm going to do right now is I'm going to take a ball probe. So that's the interfrontal sinus cell. You can actually see the roof of the frontal sinus as well, a thick bony septa, but you can see a huge block on this side. So there is something abnormal blocking it. So that's the ball probe, and I'm going to put the ball probe in that patient's right frontal sinus, and you can see that's a air bubble passing through. That was the tissue blocking the patient's right frontal. Once I take it off, you'll be able to see the patient's huge right-sided frontal sinus. So either you can use a long ball probe, the long end of the ball probe, or you can use a frontal curette. Sometimes the frontal curette does not reach there. You can see multiple air bubbles coming out. That's the sign of the presence of a sinus inside. So or you can use a 60 rad microdebrider, or else to be safe, you can use a 120-degree rad. 60 would be much more preferable. So now you can see that's the huge opening of the patient's right side frontal, and it will eventually keep on going laterally. So you gotta give thorough washes, make sure the fungus is all out. So remember that there is no superior connection through and through between the frontal sinus and the interfrontal sinus cells. Okay, it is only through the lower half they are getting connected to each other, but superiorly there is a thick bony septa. Either you can take a bone punch, or you can go externally and open up the frontal sinus and take away that septa. So now you can see after giving washes, the sinus is much more clear right now, and the Friedman's sign, that is the frontal glow, was quite evident. Now you can see there are two distinct openings with a thick septa in between. That's the opening which you are seeing right now is the frontal sinus proper of the patient. That's the actual frontal sinus. But you can see a little bit of polypoidal mucosa inside, but that's definitely going to come down after thorough post-op nasal steroid washes. And then you can see a thick septa in between and the opening of the patient's interfrontal sinus. So this is how you basically perform the surgery for such a difficult case of a frontal like this. Now I'm going to show you the anatomy of the anterior ethmoidal artery, which is way posterior to the opening of the frontal sinus. That's the opening of the sinus, frontal sinus, and the interfrontal sinus. Okay. So that's the interfrontal sinus cell, and that's the actual frontal sinus proper on the right of the patient. Below is the skull base, the bulge of the brain, but you cannot see anywhere the anterior ethmoidal artery at all. I'm going to show you the artery right now. So where my suction is right now, you can see a distinct artery. That's the skull base, and that's the artery right there, running obliquely from lateral to medial, from posterior to the anterior direction. That's the anterior ethmoidal artery down there. It's way below, so you can see I never use the intact bulla technique, and yet I always feel safe. You can see the anterior ethmoidal artery is so far away from the frontal sinus that it's not necessary that you have to use the intact bulla technique always. You can see how beautiful the artery is right now.